I'm John Tierney. I'm a local psychiatrist, and I'm board certified in general psychiatry and in geriatric psychiatry. And one of the big things we confront in psychiatry is trying to differentiate between delirium and dementia and depression. And I'm going to talk this morning about trying to make that distinction. And we're going to focus on this issue of delirium because it's really kind of the great mimicker of both dementia and depression, and it can be a medical emergency. If you do not reverse the causes underlying delirium, some really ominous things can happen medically to the patient. So we're going to look at some of the many faces of delirium and some of the psychopharmacology involved in that. I have a full-time practice across the street here from the medical school, and I'm fortunate enough to still be on clinical faculty, so I'm invited over periodically to do some lecturing here. I've written on depression in the medically ill and have a fellowship training in consultation liaison psychiatry, and taught for several years at Emory University before deciding private practice was more the life for me. Delirium, the term, comes from the Latin for out of one's furrow. So any of you farmers out there imagining a farmer plowing across his furrows and heading off in the wrong direction might have an image of what the Latins, the Greeks, had in mind when they were naming the term delirium. And those of us in the hospitals have seen patients wander down the halls dragging IV poles and IV lines, and certain that the cafeteria is conspiring to harvest their organs to serve for dinner, and all sorts of very strange circumstances occurring. So delirium, from the Latin, out of one's furrow. There was a landmark paper written in 1959 by two internal medicine docs turned psychiatrists in Rochester, New York. Dr. Engel and Dr. Romano wrote a paper that is timeless. If you sat down and read this today, you would think these were cutting-edge neuroscientists. It is a wonderful paper describing delirium as a syndrome of cerebral insufficiency. There is a medical test for delirium. It's perhaps the only psychiatric test, the only psychiatric condition with a test. Anybody imagine what that might be? It's the EEG. If you do an EEG on a patient, a normal awake person with a functioning brain should have an EEG with background activity somewhere in the range of 8 to 12 cycles per second. And whenever someone drops below that for their background activity, they are at risk for delirium. And sadly, we don't do this test very often. It's a very inexpensive test. It's easily done, and it is almost a gold standard for trying to differentiate, is my ailing, medically ill, elderly patient depressed? Or do they have dementia because they're not responding? People with hypoactive deliriums that we'll talk about in a minute, and those of you in nursing and medicine, have probably seen people in kidney failure, renal failure, liver failure. That's a classic sort of hypoactive delirium. The patient gets listless, apathetic, obtunded in the late stages, very slow to respond. They can look very depressed. And if you're not aware that their liver function is horrible or their kidney function is horrible and they're very uremic, you might think that patient needs an antidepressant, when in fact most of them don't. Most of them are fortunately quite comfortable. The hypoactive encephalopathies tend to be a fairly merciful way to die because the patient loses cognition and awareness and collective memory. And often that's very reassuring to the families throughout deliriums to remind the families that do have an intact memory that the loved one suffering this thing is not encoding new memory, and are not going to typically remember much of what's going on. And that can be very comforting to family members who are watching people go through this. So I highly recommend that 1959 article by Engel and Romano. I think it was in the Journal of the American Medical Association. Be happy to get copies for you. It's just a wonderfully written paper, describes the state of the science that's really quite up to date today. The DSM-4 nomenclature came very close to including EEGs as diagnostic criteria for for delirium under the recent revision.
You said it was in 1959?
1959, yes ma'am. When we think of delirium, I'd like you to start thinking of delirium as brain failure. In medicine, we focus and have been fascinated with organ failure. We have protocols for heart failure, kidney failure, liver failure, and we can transplant most of those organs. But there's an organ, to my mind, that we don't spend enough time worrying about in hospitals, and that's the brain. If it's from the neck up, most of us on medical teams think it still runs on vapors and humors, not unlike what Hippocrates and his colleagues were writing about, when in fact it's made of the same cells and tissue. It needs albumin and potassium and sodium, oxygen, blood, and it gets first dibs on all of those substances. And so when the brain goes bad, it is the harbinger typically of multi-organ failure. Typically it means many organ systems are already in failure, and it should be alarming to us because the statistics are such that it's a harbinger of high rate of mortality within the next 6 months, and perhaps even in that hospitalization if people don't start looking for the things that are causing that. And if you minimize it and attribute it to ICU depression or ICU psychosis, and you minimize the fact that the brain is not working like it should be, and that's a frightening thing. So a couple ways, as you see on this slide, that we believe end organ failure occurs. One is if the metabolic processes fail, so that the organ can no longer function. In other words, in the heart, if there's not enough potassium, we commonly see horrible arrhythmias, and the heart can't function without the right metabolic environment. Another way any organ can fail is if there's death of enough cells in that organ. Again, the heart, for example, if you have a big enough myocardial infarction and you kill enough heart tissue, the heart will not function properly and can result in death. The same is true of the brain in delirium and dementia. Typically, when we think of delirium, we're thinking of a syndrome in the term coined by Engels and Romano of insufficiency. Delirium is typically thought of as reversible, and the view is that there is some infectious metabolic process that is impairing the function of the brain. And so we look for reversible causes. Typically, there's a disturbance in the level of consciousness and cognition for that patient, and that's where often a definitive test is a simple and inexpensive EEG. It doesn't even have to be a full montage. It can be as simple as a couple leads for background activity. And I think in some of our hospitals, we may one day, the anesthesiologists sometimes carry those nerve conduction velocity devices, and something similar could be done with an EEG where you just put like a lead on each temple and just get a strip to measure background activity and see how slow that individual is going. Those of us in geropsychiatry tease about wanting to carry a background strip with us for people to make sure we are unconscious if we ever have to be Pavlinized or surgically treated. And most of us have heard stories of patients that have been Pavlinized and we think they're unconscious in the intensive care unit when in fact they were paralyzed and awake for a harrowingly long time in the hospital. This point is relevant because I gave you that range at the outset for normal EEG function, but there is variance from one individual to another. So if, for example, my normal background activity is somewhat fast, let's say, at, say, 12 cycles per second, well, if I drop 3 cycles per second to 9, let's say, I may look ostensibly to be in the normal range. But that change may be sufficient enough that I'm going slow enough now that I'm quite delirious. So a pre and post would be very, very helpful to identify. And Engel and Romano, as they tracked improvement from these conditions, often saw the EEG accelerate as the patient improved. Now, if we contrast that with dementia, dementia, with maybe one or two exceptions, is typically irreversible damage to the structure. So if we look at the most common dementia like Alzheimer's disease, there has been cell death. The parts of the brain are dying prematurely, particularly the areas in the brain that produce acetylcholine. So we have medicines now that preserve whatever acetylcholine function is there, basically by slowing the breakdown of acetylcholine, but they don't cure anything. They provide a certain amount of symptomatic relief. We're going to talk more about acetylcholine because anti-acetylcholine drugs or anticholinergic drugs are a leading cause of delirium in geriatric patients. And I think I have some stuff that will be surprising for you in the next couple of slides, that a lot of times this is iatrogenic, and we induce a form of reversible dementia with the medicines we need to prescribe. And we have to look to ways to counteract that. So delirium, typically a reversible problem if caught early enough. If it's not caught, cell death can occur and you can proceed to structural damage and dementia. Second leading cause of dementia, typically thought to be vascular dementia in this country, mini strokes, hypoxia, and a leading thing that we need to look for when we see a patient delirious. Worried that even though we ordered O2 by nasal cannula, if it's blowing dust bunnies around underneath the bed and those nasal cannula aren't on, it's not going to help the patient very much. So we can mislead ourselves sometimes in the things we've ordered and the things that we expect the patient's getting. But as we get shorter and shorter staffed in modern era medicine, a lot of times the things we think and want to be happening just aren't because we don't have enough help. Let's talk a little bit about DSM-4. In DSM-4, we're going to describe the criteria for delirium. But first I want to disabuse you of some of the aliases that kick around the hospital. One is ICU psychosis. I hate that term. It implies that if we just move the patient, they're going to get better. Yes, I will concede that there's some evidence that noise and sleep deprivation may exacerbate delirium. But unless you profoundly sleep deprive someone, you're not going to make them delirious. And so ICU psychosis really trivializes brain failure when a patient is delirious. If a patient's delirious, please don't attribute it to their environment. Please look for other explanations and try and treat it. There is an association. If you're sick enough to be in the ICU, chances are you got more than one organ on the brink of failure, and you've probably got electrolyte disturbances, and you may have malnutrition and hypoalbuminemia and other problems that can contribute to delirium. So certainly we see lots of delirium in the ICU. But to call it ICU psychosis often trivializes the urgency of needing to take care of the brain. Encephalopathy, I think, is a better term. My neurology colleagues use this often. And my neurology colleagues typically refer to encephalopathy as what I would call a hypoactive delirium. So those slowed down states, liver failure, hepatic encephalopathy, kidney failure, uremic encephalopathies, where the patient tends to be very slowed down in their thinking, in their movement, and they can look very apathetic and very depressed. I like the term acute brain failure personally, because when you say failure on medical surgical floors, people look to try and do something. And to date, to my knowledge, we can't transplant brains. We can transplant about everything else, but the brain we can't. We got to salvage the one we're given in this patient. And I hope with time we will address this problem with a greater degree of urgency. Reversible dementia, acute confusional state. My neurology colleagues commonly use this term when they're talking about what I would call hyperactive deliriums. The patient's very animated, maybe even a little manic, a little paranoid, a little suspicious, hard to keep in the bed, acutely confused. A good example of this is people on high-dose steroids. You can give just about anybody enough prednisone to make them look very manic and very confused. Typically, if you get in the ranges of upwards of 100 milligrams of prednisone in a 24-hour period, which happens not uncommonly in some of our pulmonary patients and patients who need immune suppression, you can cause significant confusional problems in those folks. That's probably one of the best examples of delirium in hyperactive or agitated delirium, and then organic brain syndrome. Well, having talked about the aliases, I've already mentioned too that I like this end organ failure concept, where you think about needing to have a protocol, if you will, and I'm going to suggest a protocol as we proceed this morning to addressing this problem of delirium and brain failure. If you go strictly by the current DSM-4, in criteria A for delirium, you need to have a disturbance in level of consciousness. The patient is less aware of their environment. They're less able to encode information from their environment. Often they're not sure if they're in a school, a church, a hospital, at home. Many of them think they're still at home when you quiz them about where they're located. And beyond the consciousness, this fluctuation, this effervescence between being very awake, very somnolent, very obtunded, these patients have trouble sustaining attention. They can't pay attention when a nurse comes in and tells them to help bathing or eat their meal. And a lot of times, for example, with a meal, they'll need coaxed during each stage of it, not unlike a little child. Little preschool children, part of the reason we can't send them to school is they have horrible attention spans. They're easily distracted by shiny objects and noises, and they're just bouncing around. And goodness knows my little children, preschool age, probably would have starved if we hadn't kept staying right with them through the meal, because they're so distractible and they lose interest, they lose their attention in the meal and move on. So even though an adult may look very intact, if they're suffering from delirium, if you don't test their attention, you may lose the understanding that they can't do 3- and 4-step things. And a lot of times after we've operated on them and we've induced some delirium with anesthesia and the stress and the infections and the medicines, they can't do the 3 or 4 steps to manage that IV pole, get out of the bed, get to the bathroom, let alone finish a meal. They might be able to do 1 step of it, or even 2, but the task may break down if it requires 3 or 4 phases to it. So commonly we'll test this at the bedside by giving somebody a 3 or 4 step task. We'll ask them to point to 4 things in the room in succession. We'll ask them to point to the window, the ceiling, the door, and the floor. You'd be amazed how many people can't do it. And yet when you go in to ask them as a nurse about wound care or getting around the hospital or figuring out the call button and things like that, and then in these high-tech hospitals where we've got speakers going on over their heads, these people can get very confused pretty quickly about what's going on. This disturbance of attention, we've hit upon this. It's more than just attending to a task. It's the ability to move and shift from the task. Somebody who's very delirious will commonly perseverate. If, for example, I come in and ask them to, draw a clock and put the numbers in a clock face from 1 to 12 and set the time to the clock, sometimes they'll get stuck. And if I let them keep going, that clock will have 100 or 200 numbers in it because they perseverate. They get started on the task of writing numbers in a circle and they can't shift to the next phase of the task. So they perseverate and lock in on the target and just continue counting numbers as high as they can. And they have trouble with the next phases of things. So the ability not only to attend to the task, but to shift attention when it's appropriate to other things. And that's what all of us have to do every day to be successful in our activities of daily living. Then there's this issue of distractibility. Again, I don't mean to suggest all preschool-age children are delirious, but they have delirious type behavior, the very young ones. They're very easily distracted by irrelevant stimuli. So a person who's delirious will be very distracted by overhead calls, by noise at the nurse's station, by beeps of the IV pole and pump, and this will contribute to their confusion. And commonly, because they don't have a collective ongoing memory that's intact, their brain will confabulate an explanation for what's going on in their world. And if they're scared or anxious, the story their brain puts together may sound quite sinister and broach paranoid. And they may become very suspicious that things are going on. It's not uncommon for me to visit rooms where people are on surgical floors and they hear about this limb or that organ or this problem, and they overhear from the next bed. And some of them become quite concerned that maybe we're going to harvest their organs and give them to somebody else. And their anxieties manifest in some pretty disturbing ways. Well, we've talked about this disturbance in consciousness, whether they're awake, somnolent, or maybe a little hyperactive, the problem with attention, and then there's also the problem in cognition. This is a distinction, a step-off point from the demented patient. Typically, in early phases of dementia, there is no disturbance in consciousness or attention for the demented patient. If we take the example of an Alzheimer's patient, they can be very attentive, they can be very alert, they can pay good attention. But where things break down early in the disease are higher cognitive functions. The ability to calculate, work the checkbook, work numbers. Their vocabulary deteriorates. They have trouble remembering words and doing complex cognitive tasks. If you begin testing for delirium with more complex cognitive tasks, you will confuse yourself. Because anybody who's sleeping out there right now, wouldn't be fair for us to decide that you have a cognitive impairment. If you're sleeping right now, you have a consciousness problem. We don't know until we wake you up whether you have a cognitive problem. And so too the delirious patient. If you go in and give them tests of math or verbiage, you might decide they're demented. But if you didn't already test their level of consciousness and their level of attention, you may presume incorrectly. Because until consciousness and attention are restored, you will be speculating on faulty data about somebody's level of cognition. Areas of cognition include things like memory. But if you can't pay attention, you can't have an intact memory. It's not fair to test you. But if your memory's intact and we've established that, then we can proceed to testing your memory. If your memory's intact, we can proceed to testing your orientation. If your memory's intact, you should remember that we told you you're in the hospital and why you're here and what the day or date is. But if it's not, that stuff's going to be hard to get in there. Language disturbances. When we test for stroke-type problems and aphasia-type problems, we test for the ability to repeat, for people to parrot back phrases that we say, ability to name things, the ability to be spontaneous in speech. Very common for delirious patients to have language problems. They'll have naming difficulties. They'll perseverate. They'll call things by wrong names and stick to that. They may even confabulate and make up words for things and be very emphatic about being correct. Commonly in deliriums, there's perceptual disturbances. Most commonly, they're misperceptions or illusions. They think the IV pole is somebody standing in the corner. They think the wheels of the IV pole are rodents running about the floor at night. Balloons at the foot of the bedside are particularly problematic. They can be quite scary to the delirious patient. Typically, it's misperceptions of true sensory stimuli. And this is an important distinction because we commonly mislabel these things hallucinations. To the neuropsychiatrist, hallucinations are a harbinger of something worse. Commonly, if there's true hallucinations, green men, pink elephants, Lilliputians, that sort of thing, that can indicate some more ominous kind of toxicity, either medication toxicity or possibly withdrawal phenomenon. And we'll talk in a little bit about withdrawal phenomenon that can be quite harrowing and life-threatening to the patient. So distinguishing between misperceptions and hallucinations is an important and relatively simple distinction to make. The cognition thing we've already touched on. speech and language and memory, orientation. Other things are construction and calculation. Those of you that have done the Folstein Mini Mental Status exam in geriatrics, the tasks on the back page, duplicating, replicating the sketch of the intersecting pentagons, is a classic and valuable constructional task. Construction requires integration of many brain areas, motor areas, visual areas, language areas, visual, spatial areas, and the integration into organization and planning. For somebody to have trouble with that task can be quite telling about delirium. Additionally, you will see many geriatric and neuropsychiatrists asking people to do clock drawings. Clock drawings is very simple but very elegant. Takes a pencil and a piece of paper. Some examiners will have the patient draw the circle. Typically, though, delirious or demented patients will be so micrographic that it'll be more telling for you to draw just a big circle on the piece of paper, and then ask the patient to put the numbers in it like they would a clock face in grade school. And a higher level of the test is for them to put hands on the clock and complicate it by having them organize the hands in a couple different quadrants, and to abstract, to have to use time is a very abstract concept, and to pick a number where they can't just say, 10 minutes after 2. Sort of describes numbers that are already on the clock and is relatively simple. However, 2:45 is not on the clock, and 45 takes a higher level of integration, and you got to move those hands around, and you got to get the right length and space, and it can be very telling. And there's been whole books written about clock drawing and differentiating different types of delirium based on the presentation of the clock. People with Wernicke's encephalopathy will commonly draw the backwards clock. No accident that that's seen over some bars in our country, so I'm told, the backwards clock. And other cases of the encephalopathies, hypoactive deliriums where people perseverate, they write things on, they circle the numbers instead of putting the hands on, the hands don't get done correctly. An elegant task to sort of figure out how much of a history can you rely on from this patient and how delirious do they seem to be. Criteria C, this is the bane of every nurse's existence, I think. It's sort of Murphy's Law of medicine. The delirious patient will act the worst in the middle of the night on the swing shift. That's when they will swing from IV poles, and good upstanding citizens will do obscene and bizarre things during their delirium. And then it will fluctuate, and by the time the physician's round in the morning, the patient's looking meek and genteel and quiet in bed, and the doctors are wondering why the nurses are complaining about bad behavior. So it's important to understand that it's the nature of delirium for it to ebb and flow, wax and wane. It comes and goes. It oscillates between periods of lucidity, periods of great confusion, and periods that can be hypoactive when you have mixed deliriums. Yes, ma'am.
Let me ask you this. You're talking about delirium as being brain failure, and that if the problems are not corrected, then of course death could be the ultimate outcome. So how long are we looking at that you could have a resident who might be, I say resident because I'm in long-term care, who might be actually delirious rather than demented? What kind of a time period are we looking at that this could stretch before death would incur? I mean, is there any way to say that this delirium is going to last 4 to 6 weeks, or that's not going to last that long?
Delirium can last months.
Can months?
It can last
without
months.
actually resulting
Yes.
in death?
Typically, it's going to last weeks. And typically, it's not the direct cause of death, delirium. It's signal that other things are going bad, that you've got typically, for delirium to occur, you almost always, though with some exceptions that we've talked about, like if you're in kidney failure, if you're in liver failure, that organ system alone, if it has progressed to severe enough failure. However, if you've got somebody who's metabolically impaired, if they've got an infection, and then they got a touch of kidney failure and a touch of heart failure, and they get delirious, you're going to be worried that when they become delirious, it's a harbinger that other systems are failing, and you want to look for reversible causes. So it is more an indirect indicator than a direct. And typically you expect it to improve over the course of weeks, but depending upon the compromise for that particular patient, I've seen it linger for months.
Well, the repetition of the same statement over and over and over, is that more typically delirium rather than dementia?
That's where it gets tricky. The perseveration type thing.
The perseveration of
demented patients will do all the same things.
Same things.
So typically, it's in the history. Typically, with some exceptions, dementia is a chronic condition. It's insidious. It's slow in its onset. So people progress, for example, in Alzheimer's disease. It's commonly many years, for example, from the earliest signs of cognitive dysfunction before a patient is going to need full-time care or long-term care. By the time somebody gets to that stage, they're going to have perseveration problems, they're going to have severe cognitive problems, and they will be very susceptible. Dementia is one of the highest risk factors for delirium, you see. So it's common that you will see them together. And the challenge for caregivers is to figure out, has there been an acute change in this patient? Has their behavior changed rather quickly over the last 24 to 48 hours? And typically, as we'll look at the next criteria, delirium is typically acute in its onset. So the history is very telling in trying to distinguish delirium from dementia. But dementia itself is one of the biggest risk factors for delirium because you already have organ failure occurring. You've had death of sufficient number of cells in the brain that there's very little reserve for this patient. And if you compromise more of the remaining functional cells with low oxygen or low perfusion or medications, you can push them into delirium. So it's a great question, and it's the challenge of trying to figure out when have you got which condition, and that awful answer that you can have them both a lot of the time. The waxing waning course, and here's this point that this lady just raised. Typically, delirium has an onset in hours to days. That's where your history distinguishes from dementia. Dementia doesn't usually happen that way unless you got mad cow disease or something, and it happened quick. And goodness, let's hope we don't get it here. Usually develops over hours to days, and it typically resolves in hours or weeks, but sometimes months. And even after you've got all the lab work looking good and the vital signs are good and the other organs seem to be doing as well as they can, the brain can lag behind even after things look good on paper, and that delirium can take some time to clear. This is sort of just the final point on criteria D that, as we've already hit pretty heavily, that in delirium there's almost invariably evidence of an underlying laboratory or physical problem causing this. Sleep-wake disturbance is classic, getting the days and nights turned around, judgment problems, the mood disturbance. They can be very labile as regards their mood. They can be laughing and giddy and goofy one minute and sad and weepy and crying the next. And family can often be asking for you to start antidepressants, and in some cases the antidepressants may just add to the problem. So you want to try and distinguish if delirium's there. We've talked about the EEG changes. There are certain deliriums where you also have neurologic changes. The asterixis, or the liver flap, is sort of a classic sign in liver failure. Sometimes abnormal reflexes, myoclonus will occur as the brain is compromised. Well, let's move on to talking about some of the underlying theories about this and what causes it. There's 3 neurotransmitters are key in this. We're very excited in psychiatry that we got the Nobel Prize in November. The Nobel Prize for Medicine and Physiology went to Dr. Kandel at Columbia University, a brain scientist and psychiatrist. Shared it with 2 other physicians from Scandinavia. And Dr. Kandel wrote the neuroanatomy textbook used in the medical school here in San Antonio, I think pretty widely in Texas, and is still actively on faculty at 80 years old. These neurotransmitters are much of what the underpinnings of Dr. Kandel's work. His work is primarily in learning and memory, but a lot of that work is applied in other areas. The dopamine, of course, much written and talked about in Parkinson's disease. Dopamine is the essential neurotransmitter in the substantia nigra that is deficient in victims of Parkinson's disease. Acetylcholine is missing, inadequate in Alzheimer's disease. That part of the brain is dying prematurely. Atropine. Atropine comes from the Latin term atropos. Is anybody a Latin scholar and remember who Atropos was? Atropos was the Greek god who was in charge of severing the thread of life. And if you give somebody enough atropine, you can kill them. And so there was some Latin scholar who named that drug because they knew it was tricky to use. Atropine has its advantages with certain kinds of arrhythmias, but obviously if you give somebody enough of it and you make them anticholinergic enough, you can cause anticholinergic toxicity and sever the thread of life. Acetylcholine is commonly a culprit in elderly folks. Typically, as we get older, we don't have as much acetylcholine as we had when we're young. So we have our senior moments. We can't recognize faces, remember names, sometimes can't even name things properly. Doesn't necessarily mean we're getting Alzheimer's disease. Normal aging, it seems increasingly clear from the work of Dr. Royal here at the medical school and others that normal aging probably isn't normal, that our brains deteriorate and we do lose function and flexibility even if we don't have dementia. Acetylcholine metabolism in the brain is exquisitely sensitive to low oxygen or hypoxia. If your brain doesn't get enough oxygen, it's not going to make correct amounts of acetylcholine. And if you're already low on acetylcholine, that's going to add to your difficulties. Low blood sugar will cause acetylcholine problems. Anybody who's ever worked on a kidney transplant floor has gone in and tried to get a history from a diabetic when they're hypoglycemic. It's amazing what a little blood sugar will do to clear those people up and lift that temporary delirium that they all incur during those periods of very low blood sugars. Niacin deficits and thiamine deficits can also cause significant problems in acetylcholine metabolism, contributing to delirium. Dopamine is much talked about primarily in schizophrenia. The thinking was for a long time that there was somehow too much dopamine in the brains of people who suffered from schizophrenia. It seems increasingly clear that it's more complicated than that it's probably about cell transport mechanisms and receptor problems that receive aberrant signals from the available dopamine. But it is clear that in brain injury or cell death that cells leak dopamine, and that this may be part of what contributes to the visual disturbances, misperceptions, illusions, paranoia, and is probably why the antipsychotics can be very helpful both in hyperactive and hypoactive delirium. Haldol is the one that's been most written about because we've had it the longest, and it's available through so many different routes of administration. Those of you who work kidney services may say, wow, you're going to give an anti-dopamine drug to kidney patients and people with dopamine drips going on and pressor agents. Excitingly, Haldol has no effect on dopamine pressor type activity, so it can be administered without worrying about that. So the dopamine blockers commonly help. There is an urban legend that antipsychotic medicines make delirium worse. I'm here to disabuse that legend. There is truth to the observation that if somebody's susceptible to the negative effects of an antipsychotic like Haldol, they can have a side effect of akathisia. That's motor restlessness. So you'll see them get the wiggles and the fidgets and want to move around. But if they're paranoid and they're talking about ripping out lines and leaving your unit and they're very agitated, don't abandon the Haldol too soon. Ativan will treat the akathisia. And savvy neuropsychiatrists will commonly combine the two. They can be administered in the same bolus. And you can give somebody a couple milligrams of Haldol with a half a milligram to a milligram of Ativan, and they will counteract the undesired effects of one another. Commonly, by the time you call to ask for a medicine for a delirious patient, their behavior is deteriorating and escalating. And you can mislead yourself about what's causal in that escalation if you give them a medicine and a half hour later they seem worse. Well, are they worse because of the medicine you gave them, or are they worse because they're escalating? Typically, I will tell you, I can give almost any patient enough Haldol and Ativan to calm them down, if you'll bear with me. Records have been set at the esteemed Massachusetts General Hospital in which an intra-aortic balloon pump patient received a sum total of 945 milligrams of IV Haldol in 24 hours with no ill effects, and it calmed them down. And as you can imagine, if you got somebody on an intra-aortic balloon pump, you don't want them agitated. You don't want them trying to leave the bed, because they got to leave with that pump. Those records were set before we started combining Ativan with the Haldol. Ativan's a great sedative. It calms the akathisia effects, and you don't need to go to those astronomical doses. Your pharmacy won't even have it. But it's pretty easy, 10 to 20 milligrams of Haldol IV. Rarely causes any extrapyramidal symptoms for reasons that are unclear. And a little bit of Ativan can really calm the akathisia, and the synergy between those two medicines is well documented and very effective. Other more modern antipsychotics, atypical antipsychotics like Risperdal and Seroquel and Zyprexa, unfortunately are not available from different routes as yet, and commonly these patients it's tough to give them a PO med. Some of these new atypicals are really tough on blood pressure too, and you can get a lot of hypotensive problems with them. So they have advantages, but remains to be seen that they outweigh the tried and true old medicines. GABA. GABA is an inhibitory neurotransmitter. 99% of it in our bodies is located in the CNS. When you go through withdrawal from benzodiazepines, barbiturates, alcohol, you've got a GABA disturbance, because all those chemicals are cofactors that enhance binding of GABA to the receptor. And I'll show you a little about that. Basically, there's a chloride ion channel in the brain. And when GABA binds to that receptor, it lets negative ions cross into the cell. And that makes it more difficult for that cell to fire. So it has a calming effect. If you give somebody a benzodiazepine like Ativan, it helps GABA bind to that chloride ion channel, and it helps calm that cell. And that's probably how benzodiazepines have their anti-seizure activity, their sedating effects, their hypnotic effects, their muscle relaxant effects. There's peripheral and central effects to those. The problem is if your body is dependent on benzodiazepines with short half-lives like Xanax, or alcohol, or if you're a little old grandma from West Texas who the dentist has been giving butalbital for the last 20 years for a little sleep med, and you go into barbiturate withdrawal after your elective surgery, this can be life-threatening. Seizures, coma, and death during a benzodiazepine type withdrawal. Benzodiazepine, alcohol withdrawal, barbiturate withdrawal are life-threatening in the healthiest of patients in some cases. Typically, though, things we think of as more ominous like narcotics and heroin and so forth are not typically life-threatening unless a patient is very frail and very compromised, because they're not going to have the seizures and potential coma-type problems from their withdrawal. So, barbecue. Remember your benzos, your beverages, your barbiturates, and quinolones. quinolone antibiotics have an anti-GABA effect that some patients are particularly sensitive to. So if you have a frail patient that you give a quinolone antibiotic, which are very common these days, for very benign infections sometimes, you can see these patients get very nervous, a lot of insomnia, and if they're quite compromised, some of them will get quite delirious. And a little bit of a benzodiazepine will nicely counteract that. So you need to look to see what medicines the patient is getting. And quinolones have a significant anti-GABA effect in some patients that can mimic alcohol or barbiturate withdrawal. GABA can be overstimulated by liver failure, and we've talked about the understimulation that occurs during withdrawal. During my time at Emory, I was once called to see a VIP spouse of a faculty member who the neurology service was videotaping a second time because they believed he was withdrawing from narcotics and he was having seizures in the ICU. And they thought this would be a reportable case because they'd never heard of this before. And I'd never heard of this before when they called me to see this fellow. And I interviewed him, and he denied using any other medicines. And then I explained to him that he was going to seize again, and I was worried he's going to have problems if he didn't tell me what he was really doing. Because I was taught the only thing that caused his presentation was withdrawal from alcohol or benzodiazepines or barbiturates, and he wasn't getting any quinolone antibiotics. When I explained that to him and the direness of his situation, he explained to me that he'd been using upwards of 20 milligrams a day of Xanax that he'd been shopping for all over the East Coast. And he'd been doing this for years, and when he went on a recent trip to Mexico, he ran out. And he came back for the second time to the ICU, embarrassed to tell anyone what he was doing. So I've gotten over my awkwardness of asking even VIPs, stately grandmas, and pillars of the community what they use at home. I need the absolute med list of both prescribed and non-prescribed things and things that they think may be very innocuous, like how many nips they take to get to sleep. Here's some of the numbers that have been collected over the years. In general, people talk about maybe as high as 51% of patients on general med surg floors being delirious at any given time. That's without an age limit. Post-hip fracture patients, alarmingly high. Nobody's sure quite why that is, whether it's fatty emboli from the manipulation of those bones, whether it's the length of the surgery, whether it's predisposing factors prior to the fracture, people being malnourished, low albumin, but it tends to be very high. Post-cardiotomy has been very high. New England Journal, I think, just this week talking about delirium in surgical patients and looking to things that can be done around cardiotomy and open heart surgeries to minimize the complications of delirium. Here's things that predispose people to delirium. HIV infection. The HIV virus has a high affinity for brain tissue, high affinity, and lots of the first manifestations of HIV will be mild deliriums early on in the course of the illness and cognitive problems. Burn patients, especially if large areas are burned where you've got a lot of metabolic problems, trying to maintain fluid and electrolyte balances will often predispose those folks. And then in keeping with our theme today of geriatrics, the older you are, the higher risk you are for delirium for a lot of reasons. Drug-dependent folks, kind of goes without saying after what we've said about our barbecue slide. Brain-injured folks, anybody who's had a traumatic brain injury previously, anybody with strokes or dementia is at higher risk for delirium. And then the post-operative patients that we've just talked about, people post-cardiotomy, post-hip surgery, particularly high risk. Well, what's the differential diagnosis? What sort of things can you look for when you see this brain failure thing going on? The WIMP mnemonic with 4 H's has kicked around consultation psychiatry for many years. I think it was maybe written by the same Desiderata people or something, left it on a wooden door somewhere. I don't know where it came from, so I can't credit anybody. I didn't come up with it, though. These are the things the WIMP mnemonic stands for. Wernicke's or withdrawal, got to be at the top of the list. If you have a patient in a hospital, in a long-term care setting, it's less likely, I think, that they're going to be in withdrawal. But somebody who comes new to a hospital setting, you got to worry about withdrawal. Are they coming off benzos, barbs, alcohol? Hypoxia. I had a case on a transplant service once where the family wanted to let the patient die. She was moaning and wailing, looked very sad. She had a very serious pulmonary problem. I went in to see her, and the nasal cannula were blowing dust bunnies around under the bed. And I begged the family to let me at least put the oxygen back on and get a blood gas before we euthanized the patient. And it was amazing when I went back an hour later what a little oxygen will do. That lady had totally brightened. All that pseudo sadness lifted. It was a manifestation of her delirium and her hypoxia. Hypoperfusion will do this. A lot of times we forget that patients in heart failure aren't getting much blood up to the brain. Patients in heart failure have often had coronary artery disease. And what a misleading term. Who has coronary artery disease and doesn't have total body artery disease? You know, it's like trying to get plaque-free pipes in San Antonio. You know, it just doesn't happen with the calcium here. If somebody's got coronary artery disease, you can about bet they've got total artery disease throughout their body, not the least of which are going to be their carotids, their vertebrals, and the small vessels to the brain. So anytime you see somebody in coronary artery disease, expect that their brain looks as bad, and really look to these issues of perfusion for them. Have we maximized perfusion issues as best we can? A little bit of an anemia in a patient in heart failure is really compounding a problem. Because now not only aren't they pumping very well, but the stuff they're pumping is not very oxygen rich. So there's cascades to the whole problem. And then if they've got a pump problem, they've got an anemia problem, and then they've got a pathway problem because they've got occlusions up there and it's tough to get anything through anyway, you're really setting people up for difficulties. Throw in a little hypoglycemia because they're not eating well and they're a little delirious to begin with, and you're really conspiring to create a delirious patient. Hyperintensive encephalopathy is relatively rare, but easily identified by vital signs. And an ophthalmologic exam can commonly show those bridging vessels in the eye causing problems. Worrying about bleeds and infections. People on anticoagulants, have they taken any kind of falls recently? They got only any old mild subdurals, infections. Meningitis and encephalitis. Meningitis had just hit, you probably heard, out in the Houston area a couple weeks ago. Poisons or medications, that's what I want to spend our final minutes on because that's one of the easiest things we can reverse. I carried this around in my pocket for a long time. I've got it memorized now, I'm happy to say. And it's a little easier when I come in to see a patient that I'll order labs and evaluations to kind of pursue these problems and look to get the corroborating history from family members because typically delirious patients are not very good historians. Here's some of the things that can happen in Wernicke's. Wernicke's encephalopathy is typically a manifestation of alcoholics. They have the ataxia, lateral gaze problems, they're thymine depleted. This is a classic example of if you don't treat the delirium, you're setting somebody up for dementia. People who remain thymine deficient can get Korsakoff's dementia. These days, routinely in the emergency rooms for alcoholics, we're hanging the banana bag, and we're giving them the thymine, and we're giving them the things to try and prevent the permanent damage. The withdrawal we've talked about. History is very key. Lab work. Increase in mean corpuscular volume is a harbinger of chronic alcoholism. It's a nice little test of that. High LFTs, of course. Hyperreflexia can manifest in people in withdrawal. The barbecue thing we've looked at. That's the more ominous one, the withdrawal issue. Intoxication can be a problem and can manifest as delirium. Cocaine intoxication can give you vasoconstriction problems and vagal infarcts. I'm not vasovagal, but you can get horrible changes in vascular tone with cocaine intoxication. During the withdrawal, these patients can look very psychotic. Typically, they're not physically at risk directly, but indirectly they are because of the mental status changes. PCP, fortunately, haven't seen a lot of that lately. What an awful drug that was. The hypoxia thing we've talked about, the anemia we've hit on. The histotoxic, these are the folks with COPD problems who've got so much structural damage to their lungs that, you can put, high levels of high concentrated oxygen there and it's just not helping because there just isn't the tissue to use it appropriately. The perfusion thing we've touched on. Vital signs are vital when you're assessing a patient psychiatrically. You might not think so, but want to remind you that in delirium we're looking for the underlying infectious metabolic problems causing or contributing to the mental status changes. Hypoglycemia we've talked about. In hypoglycemia you'll commonly see an adrenergic syndrome. These people are in a fight or flight mode, they're in a panicky mode, and they'll commonly have lots of perspiration and signs, physical signs beyond that quick glucometer check. The bleeds we've talked about. I'm going to skip ahead, forgive me for a minute. I want to talk about the medicines. Round up the usual suspects, look at the medication list, look for signs of intoxication or toxicity in what we're giving the patients. And here's that anticholinergic thing revisited, we touched on earlier. Atropos, severed the thread of life. He was the Greek god that severed the thread of life. Atropine comes from that name. If we look at commonly prescribed medicines on the list here, these medicines, a bright guy, Larry Toon, studied with Folstein at Johns Hopkins, had the privilege of working with him at Emory, a really smart, talented researcher and physician. In 1981, Larry went to the lab and said, you know what, I'm going to take a lot of commonly prescribed medicines and I'm going to see how they compare to atropine on anticholinergic potency. And look at this list. Prednisone, top of the list, 0.55 atropine equivalents in the lab. Prednisone is very anticholinergic. So patients get hungry and constipated and confused on high-dose prednisone. Does anybody know what diphenhydramine is? Benadryl. Benadryl. Yeah. Every intern has worked into their head that since it's over the counter, how bad can it be? Well, looky here. Exactly. It's second only to prednisone in Larry's list for anticholinergic. You want to make a little old person demented? Give them a couple slugs of Benadryl. Anybody take Benadryl before coming to work this morning? You know, it's going to put you to sleep. It's going to make you mentally dull. It's going to make you hungry and fat. You know, it's nasty stuff. And we use it all the time because we think it's over the counter. How bad can it be? Well, it's significant. Digoxin is very anticholinergic. Hydroxyzine, anybody recognize that one? It's that other antihistamine. What's its brand name? I forget. It'll come to me. It's the other. There's Benadryl and there's hydroxyzine. Coumadin, very anticholinergic. Presenting, codeine, ranitidine. Look at nortriptyline, Pamelor, barely anticholinergic. And we psychiatrists are always apologizing for the anticholinergic potency of our tricyclic antidepressants. Look down at the bottom of the list. Trazodone, great little sleep med for the elderly. It's not anticholinergic, doesn't give delirium. Got to watch, it can cause a little bit of orthostasis and can raise fall risk some, but what sleep medicine won't? You know? Triazolam, benzodiazepine, very clean. And all the benzodiazepines are clean as far as anticholinergics. And this is just an interesting list to kind of look. I encourage people to look at the med list. A lot of times patients are on essential medicines. They got to have their DIG, got to have their Coumadin. Well, in my view, you've only got so many anticholinergic units you can use up in life before you're going to become delirious. Fortunately, one of the places where these new anticholinesterase inhibitors, Aricept, and there's the other new one out right now, I haven't prescribed it yet, and there's a third one coming. These things can be miraculous in reversing anticholinergic delirium. And so lots of patients who have to take these medicines, maybe they don't have dementia, but even though, forgive me, it's off-label, and I'll qualify that, it isn't FDA indicated, but one of the first medicines for delirium was called anti-delirium. Anti-delirium. It was physostigmine. Physostigmine was a non-selective anticholinesterase inhibitor. So it made your guts go and it made your brain better, but it was tough to take. Nowadays, for real bad slow bowel, sometimes they'll still use it. These new medicines are selective for the brain. There's a butyryl cholinesterase in the brain for which these new ones are selective, so you don't get all the bowel and cardiac symptoms with that. So it's a place to think about some of these new anticholinesterase inhibitors.
So you use Aricept to counteract what might be a delirium that you are treating.
Exactly,
Dementia
exactly.
rather than
That's right. Or a patient who's got to take these kind of medicines and say, no, I'm real kind of forgetful and I'm mentally slow. A lot of those people will brighten significantly with an Aricept type medicine. And you just got to realize, you got to tell the family, look, this is an off-label use of this, but there's some literature been written about it for cognitive impairment and reversing cholinergic burden. And so you can take them there.
I have a question.
Yes.
I may have missed this when you had the list of medications that tend to cause or can trigger off delirium. Did you mention the benzodiazepines?
No, I didn't. No.
Okay.
Have you seen them cause delirium? Benzodiazepines?
No. Never have.
Certainly in withdrawal, they will cause delirium.
Oh, okay.
Yeah, certainly in withdrawal. Notable problem in delirium. Here's sort of a classic lab list for emergency causes of delirium. Looking at the Chem 20 for your electrolyte problem, CBC, looking for infections, looking for signs of alcoholism, urinalysis. Little elderly people, if they just got confused, assume bladder infection until proven otherwise. They will look delirious very quickly, and they can get uroseptic very fast. And the Cipro can make them worse, because it has that so you'll effervesce. You may make them worse before you make them better. Exactly, because Cipro's a quinolone. That's not to say it isn't a good choice, but be prepared for maybe needing a little benzodiazepine to counteract the quinolone. Blood gas. It's the gold standard. Don't be fooled by your pulse oximeter. Typically, my understanding is a pulse oximeter should be normed on every patient with a blood gas, because there's variation in skin density and carrying capacities. I haven't checked that lately, but the blood gas tells you tons more than a pulse ox. And even though the pulse ox looks good, it may be misleading about carrying capacity of the available blood. Chest x-rays, EKGs, drug levels can be very misleading. In patients that have low albumin, albumin is an important protein that binds drugs and carries them through the body. When the drug that is active, both therapeutically and toxically, is the free drug. When you get a drug level, it measures bound to albumin drug and free drug. Gives you a combined number. But if your patient is malnourished and low on albumin, your free fraction will be high. And so therapeutic and toxic effects will be magnified, and your blood level may look cold normal. So check the albumin. And if the patient's looking dig toxic, even though you got a normal level, consider the possibility that they are in fact dig toxic, and get your EKG and look for other signs of dig toxicity. Theophylline, coumadin, things that are highly protein bound, your INRs can shift around because the albumin's off. What else? There's sort of a second tier we won't talk about today. Managing delirium. Boy, trying to educate people up before elective procedures, the little old men coming in for their prostate surgeries, double checking to make sure they're not drinking a six-pack for bed before, the surgery. Because I've come in, I'll tell you, the elective BPH surgery, and nobody got the history about the drinking. This guy goes into alcohol withdrawal day 2 post-op and falls out of bed, breaks his hip, and becomes an ortho patient as well. So looking to that history on the front end, trying to prevent withdrawal syndromes, looking to the medical surgical issues, looking to the environment. Unfortunately, hospital design these days is not very friendly to patients, especially the elderly patients when they're prone to deliriums. Pharmacologic things we've touched on, reversing those metabolic infectious problems as best we can. The gold standard for delirium in the literature, still evidence-based though it is Haldol and Ativan. We know the most about these. We can use them IV, PO concentrate. I would discourage you from using IM injections in the elderly. Does anybody know why? Elderly lose their muscle, and so it's really hard to give IM injections to elderly folks because you're usually giving them a depot fat injection. It's really tough to do. And psychiatric medicines are very fat affinity. They're lipophilic. They like fat. And so if you give somebody a Haldol shot in the butt, they may have a little bit of Haldol and Ativan trickling out for a month, but you'll have a hard time figuring out whether you got your dose right and whether you're going to get a response. So PO concentrate is available on all these medicines. That's kind of nice if the patient's having trouble with pills or you got to use an NG. IV. Doses, low in the frail elderly, maybe a 0.5 milligram will be enough. Repeating it in 30 minutes or an hour. Higher doses for the more severely agitated and healthier folks. That's more than we need to know. The pearls, it's a medical emergency. It's commonly unrecognized. It's going to interfere with your best treatment plan. Has a lot of faces to it. It's commonly curable, but it can be fatal if you don't treat it. It's commonly misdiagnosed as dementia or depression, and medicines are commonly the causes. I'm going to stop there. I think my time's up. Do we have time for any questions, or we need to move on? Any questions?
No, thank you, though.
Thank you.
My class is at 1 and it's over at 9.
Question from the floor about Haldol knocking him out. How do you deal with the knocked out from the Haldol? Well, you know, I tell people before, you know, that it's guesswork. I mean, it's informed guesswork. You don't know what the right dose is. Typically, if I err on the side of a low dose, I'm going to avoid that problem and I'm not going to oversedate him. More commonly, nursing is calling me complaining that I didn't give him enough, or it's not working, or it's making him worse. And then I regret I didn't really impress him with giving him a whole lot and quieting the patient down. Because I hate it when it happens all too commonly for me. Unfortunately, the nurses will bail out on me and they'll say, "Doc, we don't like your medicine, we're not going to use it anymore. We think it's making the patient worse." I'm open to the possibility that in very rare situations it does, but I'm confident I can give just about anybody enough Haldol or Ativan to put them to sleep. There is, for some people with Ativan, a little bit of a disinhibition problem, not unlike, you know, the lampshade wearing drunk at the party. I mean, you can give somebody enough benzodiazepine to disinhibit them if they're sensitive to that, and they can look silly. Give them one more, though, they'll put them to sleep, just like the guy at the party. So you can put people to sleep and calm them down, and a lot of times that's the greater good. It's far better than, like in the House of God, you know, converting the urology patient to a neurosurgery patient because they fell out and got a subdural. So typically, starting the dose low will avoid the problem of oversedation, and then repeating the dose in 30 minutes or an hour. And after a dose or two of Haldol, I'll commonly add some Ativan if I didn't give it to begin with, and that will commonly be enough to slow them down. Typically, the half-life of these medicines is only about 4 hours. So they're going to wake up in about 4 hours one way or another, commonly. But you can oversedate people, and you can have them sleeping right through the next day. By definition, when you're treating a delirious patient, you're treating a brain in failure, and it's pretty sensitive to a lot of things. So it can be sensitive to your therapeutic interventions as well. Other questions?
I'd like to check with you. I think you mentioned that Ativan calms akathisia.
Yes, ma'am. Yes, Ativan. The benzodiazepine lorazepam is very effective for akathisia, and we prefer that. Typically in psychiatric, young healthy psychiatric patients, you know, we'll use Cogentin and Benadryl. Well, why is that a problem here? Exactly. Cogentin and and Benadryl are anticholinergic. That's why they help the extrapyramidal symptoms. You're balancing what you do with dopamine and acetylcholine in the substantia nigra. But the last thing we want to do to a delirious patient is subject them to a standard treatment for extrapyramidal symptoms, cogentin, because we're giving them a bunch of anticholinergic load when we're trying to avoid that. So the benzodiazepines work in a more clean fashion to calm that. Any other questions?
When we're talking about geriatrics, I'm sure you can answer this about pediatrics with the Benadryl. What do you think about that?
Benadryl in pediatrics, you're not asking about my children, right? You just mean in general?
In general.
No. Yes, Benadryl works great in pediatrics, speaking from experience with my children. It makes them sleepy, and it's a great little antihistamine. You know, I know of no toxicities with sort of standard doses of it. The problem in the elderly is and again, it's not really particularly, it's not toxic, it's not injurious in any direct way, but indirectly it's compounding a problem. Is why I like to avoid it in the elderly. In pediatrics, I think judicious, low use of it for kids that need an antihistamine, for example, kids with bad allergies, and you want to give them a little sedating antihistamine at night to help them sleep, as opposed to the decongestants, which some kids are real sensitive to and will really mess with their sleep, and they just can't take them at bedtime. The Sudafed type things, and what are those? The syrups that they give the kiddos to help with their allergy and congestion problems. So a little bit of Benadryl can be quite helpful for them. It wouldn't be fair to test them the next day cognitively necessarily. I expect them to be a little slowed down maybe. All right, well, we'll stop there then, I guess. Thank you very much for having me. Appreciate it.
Thank you. Please be sure and let Lily make a copy of your program. That was excellent.
Oh, okay.
It was excellent. I've got one little lady that I think is delirious now rather than demented, so I have to come and work with her doctor.
Yeah, exactly.
What goes up must come down. Spinning wheel, got to go round. Talking about your troubles, it's a crying sin. Catch a painted pony, let the spinning wheel spin. You got no money and you